So I'm going to speak to you about traumatic shoulder instability, and it was specifically remarked on position players because typically this doesn't happen in our pitchers, and if it does, usually it's a fairly traumatic injury, and most likely they're going to proceed to surgical management on a very urgent basis. So these things can happen in our position players, and so how do we manage this? These are my disclosures, as I've mentioned before, and this is an example of what can happen here. Here's our right fielder diving for a ball. He's big enough to be a linebacker. He's about 6'3" and 240, and he lands in an awkward position with his elbow on his catching left arm and hurts his shoulder. He's aware of what's going on enough to be able to throw the ball, but he can't really use his left arm. And I'm going to show you what happens. But he felt like his shoulder slipped out of place. Here's another example where the shoulder is out the bottom. So here diving for a pitch that's diving for a ball that's out of play, and you can see he can't move his arm because the shoulder's dislocated out the bottom. It wasn't the first time that shoulder had come out of place. It's reduced, just like there was the actual pitcher, the player that we had didn't need a reduction. His shoulder went back into place, and of course the immediate question is, when can they return back to play? What is the criteria return, and what is the risk for return? And for many of these athletes, it's if it's their non-throwing arm and they're a position player and it's during the season, we will try to figure out a strategy to get them back to playing if we think it's safe to do that. And so we know from the football literature in particular, even playing a collision sport, that there's reasonable evidence that you can get the athletes back. And this is a paper that was done more than 10 years ago, and it's been upgraded now with a more recent paper from some of our colleagues in the military academies and others. And what they found is that if the patients had pretty good function soon after the instability event, the return to play was relatively rapid. And overall, if you looked at this, about 27% would return to play and have no recurrent instability symptoms, but the other 67% did have instability symptoms, typically 2 or more throughout the season. There was no difference between the initial dislocation or if they had a subluxation event in terms of experiencing this, and then the subluxers were more likely to return to play than the dislocators. So what this means is that we do have the opportunity to pause for a moment and not say, even if they're a professional athlete or a high-level collegiate athlete, they have to have surgery. Can we get them through the season? And a number of them will get through the season, especially if it's their non-throwing arm. If it's the throwing arm, then all bets are off, and most of us are going to proceed with a surgical management. Is there a role for immediate surgery for a first-time traumatic dislocator? This is a constant source of controversy. Again, in our overhead throwers, if it's the throwing arm, most of us would lead towards surgical management as our initial intervention. But if it's their non-throwing arm and they're able to bat and field and play the position well without recurrent symptoms of instability, we may be able to get them through the season and manage them and see how they do. We know with surgery that we can dramatically reduce the incidence of recurrence of instability over what's been reported in non-operative management. And with physiotherapy alone, unfortunately, recurrence rate, at least 2 out of 3 are going to have experienced more instability, and that repairing them from the very beginning, we're going to reduce that incidence dramatically. This is our right fielder. This is what he did on that fall. And so within a week, he was in the operating room. You see that not only did he tear off his labrum, but he knocked off about 15 to 18% of the bone on the front of his shoulder. And notice how this labral injury doesn't stop at the 6 o'clock position. This is his left shoulder. He's on his side. But this injury goes all the way around to the 6 o'clock and even around to the 4 o'clock position posteriorly. And it involves his superior labrum also. So it's a fairly traumatic and dramatic injury all the way around the shoulder joint. And so we did not wait on this and repaired his shoulder. And we have techniques, just like Chris showed you posteriorly, where we can use knotless fixation in some of our areas. So here's an anchor back here that was securing it. There's ones around the top. There's ones around the front. We reduced that bone fragment as well as inferiorly, and he was able to return back to his position at 4 months after his injury. So his injury occurred in the first week of the season in April, and he was back in August playing the same season with his non-throwing arm. So there probably is an important role to consider for those who have a bone injury or a significant labral tear, more early intervention. We have some trouble discussing this among all of ourselves because we don't define the injury very well. We all know that that anterior band has been stretched and some part of the inferior aspect has been stretched, and we think most of the time the rotator interval is okay. And most of our players do not have a problem with the bone injury, as you saw here. That really led us to surgical management right away because we feel that the bone injury is a more dramatic problem, less likely to be successful for non-operative management. But you see here someone who's had multiple dislocations, and again, just reiterating the fact these injuries go past that 6 o'clock position and all the way posteriorly in some of our patients, and we have to have the tools and tricks available to manage that. We can't solve all the instability problems arthroscopically. This is one where the glenoid, about 20% is missing, and then you'll see the back of the humeral head has been pretty badly damaged because of multiple dislocations, and this usually requires a bony operation to solve the problem. We do manage these arthroscopically. We've reviewed this in our own cases, and then there's also been a number of systematic reviews as ones that we've done, and basically we find that the recurrence rate overall is about 8% with the modern day suture anchor techniques, and we think this is quite reasonable. And we know that we have to use these techniques where we put 3 anchors below the 3 o'clock position on a right shoulder, and then we extend that repair. So we'll initiate that in the main part of the area where the instability is at in the anterior part of the right shoulder. We'll extend that as we need to, both superiorly and posteriorly, depending on the lesion, to make sure that we stabilize the shoulder. We feel that this is best done in our hands in a lateral position because of that inferior component of instability. So our patients are put in the lateral decubitus position and their arm is suspended so that we can see around the glenohumeral joint. And the literature would suggest that we're oftentimes able to do a better job in this position with instability problems too. We are able to get 360 degrees around the shoulder with this position, and that can be really valuable in treating these lesions. Here's just another example. This is the posterior aspect of the shoulder joint where that lesion comes around. I've already showed you a number of examples, and you can get to all quadrants of the shoulder with this lateral position and manage these patients very well so that we access that inferior and anterior aspect of the shoulder and fix this well. We also make a very big effort to make sure that we're not only bringing the labrum just onto the rim, but moving it up into a more superior position. So here we've already got 1 or 2 anchors below at the 6 o'clock position, and now we're reaching down and grabbing, and you saw Chris do this too, and we're gonna pull that labrum and capsule up onto the rim. So both a superior or north-south shift as well as onto the rim to make sure we stabilize this. And we now add biologics in a lot of our athletes in hopes that this will improve the healing rate and the recovery. There are times when we have a bone lesion, mostly on the humeral side, and the glenoid side looks pretty good. And we've also learned that you can place the soft tissue here into that and fill that defect, a technique called a remplissage, and improve your results. And again, this is again in a position player, typically the non-throwing arm. We will use these techniques to manage them arthroscopically, because we've learned over the years that if they have a real bone lesion, as was shown many years ago, the recurrence rates are too high. Without a bone defect, it's under 5% in this series, but with a bone defect, 2 out of 3 patients had a recurrence of their instability. And we know from a variety of different authors from around the world that that bone defect is the main reason why we get a failure. And that defect is not that large. It's somewhere around 6 to 8 millimeters for many of our patients. And in a revision situation, it may be only 4 millimeters of bone loss combined with the stretching or damage to the soft tissue that may lead to a much higher recurrence rate. And we have to think of a different procedure to manage that. We use a CT scan to really identify this ahead of time, and for the majority of our athletes that we're treating in the baseball world, they're going to be in this arthroscopic repair, less than 15% bone loss. We're able to incorporate any small bone fragments into our repair. We use a minimum of 3 anchors, and then also extend it posteriorly as needed to manage this. Now, in those few cases where bone loss is dramatic, and we can't fix that early as we did in our one player, then the operation that really is the standard of care in 2016 is the Latarjet procedure. And some may argue with that, but this is really an operation that works extremely well, and we're able to get the athletes back. They don't get their full external rotation, so you wouldn't want to do this on a throwing arm if you could avoid this, but they can play just fine if it's done on their non-throwing arm. They can bat, they can field, they can play all the other things that they need to do after a Latarjet procedure if you're careful not to over-constrain the capsule, and they will be stable with this operation in the vast majority of patients. Now, after these types of surgeries, how do they get back to sport? Well, even in a collision sport like the NFL, we can see with arthroscopic reconstruction, we have better than a 90% return back to sport, and that's really good. As you see here in a systematic review from around the world, again, there's a very high rate of returning back to sport in our non-collision athletes, a little bit lower in our collision athletes. So when you have someone who has a truly traumatic collision type injury, like a rugby player, you would consider that most of these, a third to 50%, will have a significant bone lesion. And if you can address that early on and you're doing it more chronically, you're going to have to consider more the Latarjet than an arthroscopic repair for these individuals. Again, different than what we're talking about with our baseball players, but I want to make sure you understand that and don't generalize that to all the different types of patients that are out there. So the take-home message is that a soft tissue stabilization works well. In the non-throwing shoulder, we may be able to extend their time throughout the season, but if there's any bone loss or an extensive labral tear or recurrence of instability symptoms, then early surgical intervention is recommended. When there's bone loss, the Latarjet is the procedure of choice, and that the ideal arthroscopic anterior stabilization used to be a variety of contraindications, but now really the only thing that stops us from doing it arthroscopically is typically glenoid bone loss for these individuals. Thank you very much.